Face and neck injuries. Obviously, the face and neck are very vulnerable to injury, to blunt force trauma, penetrating trauma, any kind of trauma you can suffer. I believe you can suffer to your face and neck. I guess short of maybe trauma to the genitalia. I guess you can't suffer that trauma to your face and neck, but mechanism of injury, things we need to look at. Do we have a low velocity penetrating injury? Do we have a high velocity penetrating injury? Knife wounds to the face and neck, especially the face, seem to be relatively common. That would be low velocity. Maybe a stab wound through the cheek. It seems that a lot of the low velocity injuries to the face, if you're talking like a knife blade, are more of a slash type injury rather than a stab type injury. A lot of times it seems like people are they have defensive wounds on their arms, and they're able to get their arms up and maybe block some of what would otherwise be a stab type wound to the face. Things you need to be concerned about as you think about mechanism of injury giving rise to index of suspicion. If you have a low velocity penetrating injury to the face, you're worried about airway. You may not be worried as much about C-spine. If you have a high velocity penetrating injury to the face, a gunshot wound to the face, you definitely need to be worried about C-spine. Look at the entrance wound, exit wound. What type of trajectory does it appear that the bullet followed? Do we expect a lot of cavitation? Do we have a through and through high velocity penetrating injury? Err on the side of caution and manage that C-spine. When we talk about head injuries in the next chapter, I'll give you a couple of caveats there too, that will be things you at least need to think about. And I'm not saying you don't manage C-spine, but there are some things you have to expect, and I'll save those for then. Okay. Any wounds to the head and face bleed extensively. Be amazed at how much a 1 centimeter laceration to the scalp can bleed. It looks like your patient lost his entire blood volume. It's dripping out of the hair, running down the face, soak the shirt, and you put pressure dressing on there, and you get to and deliver your patient at the hospital, and you come back a couple of calls later, and you always pop in to check on your patient, or at least I always did, and you expect to find this patient with this giant gash that was down in the hair, and you had trouble visualizing it, so you just controlled the bleeding, and you get in there, and there's a little bitty shave spot with 1 staple in it, and it's like, oh man, thought you had half your head cut off, and you'd bled out at least 42 liters of blood, more than the average human possesses, but nope, turns out it was probably 20 cc's of blood, and it was a 1 centimeter laceration. Okay. Wounds to the neck. Other things to be concerned about there. We're gonna learn. One would be an air embolism. You have a injury to one of the vessels in the neck, one of the external jugular vein, as we've talked about all semester, and fortunately now you've learned what the heck you're trying to assess and why it's important when it comes to those jugular veins. But if if you have a laceration that cuts one of those, then you can pull air into your patient can pull air into that laceration in that jugular vein, and that can cause an air embolism. Which, what could that cause? It depends on how much air. It could cause anything from an air pulmonary embolism to it just depends on where the air goes, right? I guess it could conceivably it's probably going to be a pulmonary embolism. So I'll stop there. I mean, it could cause a stroke. It could cause uh, uh, an air embolism in a coronary artery and cause a heart attack. But I think those are remote possibilities, because that air would have to make its way all the way through pulmonary circulation back to the left side of the heart, and either enter coronary circulation in the coronary arteries or systemic circulation and make its way to the brain. So the most likely would be an air pulmonary embolism. But I'm not saying the other hasn't happened. It's just following the path of that air, it's more likely to be a pulmonary embolism. Okay. We need to be assertive in assessing these patients and treating those life threats. And we'll hit more of those in a minute. The anatomy and physiology we're going to go through fairly quickly here. We spent quite a bit of time on the brain in 2 chapters. One of them was the human body chapter. The other was the neurologic emergencies chapter, where we talked about strokes. Obviously, the cranial vault contains the brain. You have the cerebral hemispheres. So you have right and left cerebral hemispheres. There's the right and left parietal lobe, frontal lobe, occipital lobe. Frontal lobe is obviously the frontal skull. Occipital lobe is posterior. Okay. You know what the face is comprised of. You by now should be starting to get a handle on what the bones of the face are, the nasal bones. Most of what you see with what we call a person's nose has very little to do with the nasal bones. Mostly it's cartilage and skin. Some of us have a whole lot more cartilage and skin than others. That would be me. Zygomatic arches, that's the inferior portion of the orbit. The medial portion of the orbit is comprised of the nasal bones, and then the frontal skull makes up the superior portion of the orbit. And facial fractures, depending on where they are, can paralyze motor nerves that allow the eye itself to move around within that orbit, and you can have one eye that tracks and moves, the other that is stuck in place. Sometimes that's a temporary situation, sometimes that's a permanent situation. That's not something we're going to determine pre-hospitally. The inferior portion of the sorry. Okay, then the maxilla is what the upper teeth are mounted in. That's not the right term, but the upper teeth sit in the maxilla, and then the mandible holds the lower teeth. You know what all that's for. The purpose of the orbit is protect the eye from injury. We see very little of the globe of the eye when we look directly at our patient. The majority of the globe of the eye is contained within that orbit. The portion that's exposed is very, very susceptible to injury. Okay, I talked about that. Uh, the ear, that's comprised of cartilage and skin. What is the tragus? That term, uh, true confession, I think until the 10th edition of this book came out, I kind of used to pride myself on my knowledge of human anatomy, and I didn't know what a tragus was until the 10th edition of this book. Maybe I just didn't pay good attention. But if you put your finger in your ear canal right there in the ear hole, like you're going to plug up your ear so you don't have to listen to me talk, and then pull it out a little bit and move anteriorly, that little flap of cartilage that you can push down to cover your ear canal, that is the tragus. And some books teach that you measure an oropharyngeal airway from the tragus to the corner of the mouth rather than the angle of the jaw to the corner of the mouth. So if you see that pop up in any material in the future, you'll remember that the old fat bald guy took a minute to explain what a tragus was and admitted to the fact that until about 8 years ago, he didn't know what a tragus was. So I wasn't sure it was something we were supposed to talk about in polite company, as my grandmother always said. All right. And then just anterior to the tragus, you're going to find the superficial temporal artery. Why would that be important? If your patient has a laceration to that area, you could expect extensive bleeding. Fortunately, that is fairly superficial, and direct pressure should work to control that bleeding. The neck, there is a lot of stuff crammed into a short area. In case you didn't know, the neck begins right there at about the clavicle line, and it extends up to one of my chins. It's up there till all the way up to the mandible. Everything is packed in there. Notable things within the neck, anteriorly, of course, is going to be the trachea. Lying behind that would be the esophagus, and further posterior to that would be the spinal column. Spinal column provides the structure and support, part of the support for holding the head erect, and then this tangulation of muscles. Sternocleidomastoid muscle is what allows us to, one of the major things that allows us to move our head. Another noteworthy structure to look at here, the large portion of what we call the larynx as a combined structure. The superior cartilage is the thyroid cartilage, inferior is the cricoid cartilage. Between the two is the cricothyroid membrane. Come back and see us for advanced EMT class, and we will teach you how to make an incision vertically up and down in a patient's, through the skin, and a little bit of muscle in the anterior portion of the larynx, and then pop some forceps through the cricothyroid membrane and insert a tube, and what you have just completed is a surgical airway in a patient who may have tremendous amount of edema in their oropharynx that is occluding their airway, or they may have massive facial trauma, and and no way to get an airway, but we can do this simple surgical procedure that's within, in Texas, it's within the scope of practice of an advanced EMT, as is endotracheal intubation, and that would be the non-surgical version of passing an airway through between the vocal cords to secure your patient's airway. If you go west to New Mexico, advanced EMTs do not grab a laryngoscope to perform endotracheal intubation, and it's not within the scope of practice in New Mexico for an advanced EMT to do a surgical airway. So what I've just demonstrated is that legal creature called scope of practice, which determines which golf clubs you get to have in your golf bag when you go play your game, if we have any golfers. So maybe some states or some jurisdictions let you have a driver, a mid-range iron, and a putter, and that's all you have to play. And maybe another jurisdiction allows you to have all the clubs that you might find in Tiger Woods' golf bag. Can you play golf with three golf clubs? Yes, you just have to play a little differently than you do when you have the full complement of woods and irons and a putter. So that's enough of the golf analogy. Since I messed up my back and hip so bad I can't play golf anymore, so this time of year I get lonely for the golf course. That's where the golf analogies come from. Carotid arteries, fairly superficial, easily palpated. Hopefully you can take a carotid pulse by this time in this course. And then not shown in this diagram would be the external jugular veins, and we've talked about what can happen with the laceration of the external jugular vein. As you can see, penetrating trauma anywhere in the neck can cause some significant, can pose some significant life threats in our patients. All right, so this is a better picture of what I was trying to describe in that previous one. Okay, enough of that. So remember that this divides the upper airway and the lower airway. So the posterior pharynx is going to terminate here at the larynx, dadgummit, sorry, larynx, where the vocal cords reside within this structure that divides upper airway from lower airway. And lower airway, that's going to be the trachea, and then that divides into right main stem bronchus, left main stem bronchus, bronchioles, and then takes us down to the alveolar sacs where the magic happens, right? What happens in the upper airway and the lower way if you exclude the capillary beds and the alveolar sacs? Ventilation takes place everywhere above those alveolar sacs, and then within the capillary beds and the alveolar sacs is where respiration takes place, the exchange of gases, what keeps us alive, right? We're going to do good if my voice holds out this whole time. Okay. 80% of the eyeball is protected. Depending on the trajectory of penetrating trauma, almost the entire thing is at risk, but most of it is protected, and most injuries that you see will be in, or at least will initiate within that 20% that's exposed. And we'll talk a little bit about some of the types of trauma, how to recognize it, how to treat it. Anterior chamber, is filled with aqueous humor, and then vitreous humor, the jelly-like substance that maintains the shape of the rest of the globe of the eye, and that vitreous humor, that jelly-like substance, is back here in the portion of the eye that I'm circling with the cursor of my mouse. Years ago, we taught, not that many years ago, we taught that if the vitreous humor of the eye was lost, the eye was totally lost, and nothing. Oh, I'm sorry. Sorry, I'm looking at one thing, talking about another. So if the vitreous humor of the eye is lost, we can't replace the vitreous humor, and that's going to result in a loss of the eye. And I'm not an ophthalmologist, nor am I an optometrist, so there may be exceptions to that, possibly small losses of vitreous humor. Maybe that doesn't result in total loss of vision within an eye, but a massive loss of vitreous humor, and you'll see these on rare occasion, fortunately, but you will see these things that gross Buddy out and make me go, ooh. If I see vitreous humor running down somebody's face, it kind of sends a shiver up my spine. Hopefully my patient never sees that I got a shiver up my spine, but that's an ominous looking sight. You have a patient who fears they've lost their vision, and you have an old clinician here who is quite certain that patient has lost their vitreous humor and will lose their sight. And worse than that even is a couple of times when I've had a patient who had vitreous humor running down both cheeks, and it wasn't splashed from one to the other. I had a patient who was a seeing person moments ago. Maybe I had a 5-minute response time. Maybe it took 60 seconds for 911 to process that call and dispatch an ambulance. So 7 or 8 minutes ago, you had a person who was a seeing person. Everything was cool. Everything was great in their lives. They could look at their kids and they could see their kids' faces, their spouses' faces. They could engage in their occupation and their recreation. They could open a book and read it. They could pick up a song book at church and maybe sing a song. And now their entire life has been changed. I've only run a couple of those, and I'm really glad. One was a little kid. That's even worse. And I had people tell me, oh, kids are adaptable and that, but I have that term for that's bull crap. Kids are adaptable, but man. All right. Lacrimal glands provide tears which lubricate the eyeball, or demonstrate an expression of emotion, I guess you could say. Sclera is that white, tough tissue that helps maintain that globe shape of the eye, and then internally you have that vitreous humor that helps maintain that globe shape and provides some cushion to the retina and to the structures of the eye. Of course, light enters the eye through the anterior chamber, goes through the cornea. That should be a totally transparent layer, and then posterior to the cornea is the iris, which is the colored portion of the eye. As the nervous impulse reaches the reaches the iris, reaches I think that's the papillary muscle. Don't hold me to that. That is what contracts and relaxes to dilate and constrict the pupil, and that controls the amount of light that enters the eye. And if I got screwed up on my anatomy just now, I apologize, and I'm open for the insertion of the right word because it left me. Okay. Normally, pupils are equal and they react to light in the same manner on both the right and left side. I've never encountered a patient who had more than two eyes. I don't want to. Anisocoria is a person is a condition where a person is born with two different sized pupils. That does not indicate anything is wrong with the patient, whether it would be damage to the eye or to the nerves innervating the pupil, nor does it mean that the patient has an increase in intracranial pressure, which is causing them to have unequal pupils. It may be that they're born with anisocoria. So how the heck do we find that out? If we say, have you been diagnosed with anisocoria? They may not know what we're talking about. What do? We're getting a sample history. Or just as we're doing, because we've taught you to quickly assess pupils in that primary survey. Why? Because I told you that if a patient has sluggish pupils, that could be a sign of increased intracranial pressure or hypoxic insult to the brain. So if we assess those pupils quickly during that primary, and we see that our patient has two different sized pupils, that could indicate increased intracranial pressure. If that patient is conscious and can communicate with us, that's not a bad time to quickly say, has anybody ever told you you have two different sized pupils? They're either going to say yes or no, or they're have a closed head injury, and we might as well be speaking Martian to them because what we say doesn't make sense. So that's how quickly you can do something like that. It took me 90 seconds to stumble through it, but it doesn't have to wait till you're getting a sample history. It would be a good thing to know right now. If I'm in my primary and I see unequal pupils, hey, has anybody ever told you you have two different sized pupils? Yep. All right, I feel a little bit better, but I still need to assess for other signs and symptoms of a closed head injury, which we'll hit in the next chapter. I also noticed that the summary outlines that I've posted, I caught up and I got behind. So I will get those summary outline for the next several chapters. I'll get those up for you today or tomorrow, because some of you have told me that helps you prepare and study. So I'll stay on top of that. I thought I was further ahead than I was. Okay. If your patient has altered mental status, which would include being unconscious, unequal pupil size, can mean one of three things. Could mean an injury to the eye, could mean a closed head injury. Number three, it could mean anisocoria, right? Okay. Then the lens focuses light on the retina, and the optic nerve extends posteriorly from the retina. The optic nerve is one of the 12 optic nerves, are a pair of the 12 pair of cranial nerves that we have in the base of our brain. Okay, we've talked about those two different times now. Okay, what do we need to talk It says retinal detachment causes blindness. What causes retinal detachment? A lot of times it is blunt force trauma to the head. Retinal detachment is not uncommon in boxers and in other sports where there are violent blows to the head. And we'll talk about those more in just a minute, but we'll plant the seed now. All right. Trauma to the neck can cause edema, and that edema can lead to complete obstruction of the upper airway. That makes sense, right? We didn't really have to come here to know that. People don't like to get clotheslined. That's illegal to clothesline somebody in football. What does that mean? Hold your arm out and catch them by the neck as they come by and cause blunt force trauma to the neck. That could kill somebody, right? Direct injury. Okay, let's see. Yeah, we'll talk about all of that in a minute. Stay on top of the airway from beginning to end with neck injuries. That swelling over the course of a transport, your patient can start to get into some trouble. So at the BLS level, if you're on a complete basic life support ambulance and you have a patient with trauma to the neck, and you see that as you reassess, you see more and more swelling, you see that edema progressing, don't wait until it's too late to get an ALS truck on the way, somebody who can perform a surgical airway. It may be that a surgical airway, that would be the last resort. Could be possible, even though you have that swelling of the neck, to go ahead and just place an endotracheal tube. If that damage is further down the trachea, the patient has a fractured trachea, that surgical airway, unless they push the tube down into the right mainstem bronchus, they have big time trouble. Come back to paramedic school and I'll teach you about intentionally intubating the right mainstem bronchus in a case of tracheal trauma so that you can provide oxygenation for your patient. Soft tissue injuries, these can be dramatic looking. They can be very painful. They can bleed a lot. This little old person, I say person because sometimes patients in the nursing home, just looking at their faces, it gets hard to tell if it's a man or a woman. So sometimes they all start looking alike. So I think this is a man, but so our elderly patients with facial trauma and head trauma, for that matter, is that secondary to fist fights and boxing and playing football and driving too fast on a motorcycle and falling off and whacking your head on a telephone pole? No, that's what is the mechanism of injury that causes the soft tissue injuries to the face, head, and neck of our elderly population? That's going to be falls. Dental injuries, very little we can do for those other than we need to make sure we provide a good airway for our patient. And if there are dislodged teeth, try to take them with us. Fractured teeth, there's not a lot we can do for. A tooth broken in half, but we can haul the pieces. Usually you can't find the pieces to take with you. And you're not going to spend time on the scene of somebody who has massive facial trauma. We're worried about a closed head injury and a possible spinal injury that goes with that, and missing teeth. The last time I checked aren't life threats. So unless we have isolated trauma that caused the loss of a tooth and we're not worried about life threats, we're not going to be worried about collecting a bunch of teeth and pieces of teeth. Maxillary fractures, you don't see as many of those as you do mandibular fractures, I don't think. What would you see? Massive facial swelling, instability of bones as you palpate your patient's face and you palpate around the zygomatic arch and then down onto the teeth. And then what am I going to have my patient do? I'm going to have them bite down and see if they can in fact close their teeth, and see if they grimace, if they're make that face like, oh my gosh, that hurt, which they will. And then ask them, did it feel like all your teeth lined up right? They know, they've been carrying these teeth around for their entire adult life, probably since elementary school for most people. They know what it feels like when they line up. They know what it feels like when they don't. So ask that question. That's something you need to know. It takes quite a bit of force to cause a maxillary fracture. So that mechanism of injury is going to give us an index of suspicion that our patient might have a closed head injury, and we're going to need to assess for that also. And when you are checking pupils, we're assessing for pupillary response, you take your pin light and you start from the outside and go. So you start laterally and go medially to check pupillary response, and then go to the other side and start laterally and move medially to see what that pupillary response is. We measure pupils in millimeters, so we visualize those pupils prior to shining the light. How many millimeters does that appear to be? Well, heck, how do I know that? There a lot of your pin lights will have a pupil gauge on the side. It'll have 1 millimeter, 2 millimeters, all the way up to 10 millimeters, and that's how we get an idea of pupillary size. Don't sit there all day trying to decide if one pupil is 2 millimeters and the other one's 3. Do they look like they're close to the same size? Do they appear to be approximately the same size? That's what we're looking for. Does the pupil appear to be round, or is it misshapen? If it's an irregular shape, that can give us an idea that there's trauma to the iris, at least, that's making that pupil not appear to be round or almost round. We assess for discoloration, bleeding, redness, eye symmetry, pupil size, reaction to light. We also assess for eye movement. So after we've checked pupils, somebody pipe in and tell me, can you see what I'm doing with my pen here, playing like it's a pin light and playing like those are my eyes? Can you tell what I'm even doing, or can you even see me right now? Anybody? I may be just flashing this. I think you can see me, but I think it's real small and in the corner. Maybe you can see after you've assessed pupils for pupillary response, symmetry, pupil size, all those things. We also want to assess for eye movement. So we're going to tell them, hold your head straight, keep your head straight ahead, perfectly still. I want you to follow my pen with your eyes. And you'll notice that your patient's eyes track together. So we're going to go over to the side so that they follow the the vertical pin over to their left, back to center, over to the right. Turn the pin so it's horizontal now. Have them look up, back to the center, have them look down, then take it up and to the left, down to the right, back to the center, up at an angle to the right, and then looking downward to the left. We have now assessed ocular movement to the cardinal points of the compass, and that tells us, that can tell us a couple of things. It can tell us about damage to the nerves, the motor nerves that allow for ocular movement. Also can tell us about our patient's ability to hear and follow directions, which tells us, gives us an indication of what? Their mental status. So as we assess these things and we have patients follow directions, that can tell us about more than just how their eyes move around. But that is important in a patient with an eye injury. Now you have a patient with multi-systems trauma who is about to die right in front of you. You don't have time to play around and assess all that ocular movement like I just did. That's part of your secondary. That's deep down into your secondary. When would I be doing that? If I had managed life threats and I was down to, or I'd assessed for life threats in my primary, and I'd done a good sample history and covered my OPQRST, and now I'm moving through my head to toe exam as part of my secondary survey, then I may be down to doing my focused examination of my patient's eyes, and my patient has isolated injuries to the eyes. I can assess those things. Another time that I would not be having my patient try to track my pin light or my pin all over the place would be if they have penetrating trauma to the eye, if they have an impaled object in their eye. Obviously, we don't want the eyes moving around. Everybody's seen Pirates of the Caribbean, because when I talk about impaled objects in the eye, I always think about the guy with the prosthetic eyeball in Pirates of the Caribbean, and the cannon fires and he has the fork stuck in his prosthetic eye, and as he moves his eyes around, the fork moves around. Don't have your patient do that, whether they're shot in the eye with a fork from a cannon or they have mascara. I think that's what you call that stuff that you put on your eyelashes. Had a patient one time who was accelerating on an on-ramp in morning traffic on her way to work, and in her rear view mirror she was putting the brush stuff on her eyelashes, whatever you call that, and all of the traffic stopped in the on-ramp except for her, and she rear-ended, almost said what I always call that. She rear-ended the car in front of her, and she impaled that brush thing in her eyeball and had vitreous humor running down her face. It was a bad day for that eye. She was quite hysterical. I maintain, not to her, but later I maintain she should have thought about that before she tried to drive and put brushy stuff on her eyelashes at the same time. I don't know much about makeup, obviously, but that's one day she wished she hadn't worn eye makeup. Well, she didn't really get to wear it because she cried all of it off on the other eye, and she didn't really get it all put on that eye. But oh man, that was quite a day. That still kind of makes me have a shiver up my spine. Okay, get a good baseline set of vitals. Control visible bleeding. If your patient has trauma to the face, how do we determine if they have bleeding in their mouth and in their or in their oral pharynx. We have that little fancy pen light that we just, it has a pupil gauge. I talked about it, 1 millimeter up to 10. That is fancy. What else can you do with that? What else better you be do? What else should you do with that? We're going to look up the nose to see if we have any possible cerebrospinal fluid running down from the nose. We're going to look in the ear canals for the same thing. Then I'm going to have my patient open their mouth, and I'm going to look in and look for fractured teeth, and I'm going to look for bleeding inside the mouth and bleeding in the posterior pharynx as far as I can see back there. And if there's bleeding in the mouth or in the posterior pharynx and I have a patient immobilized on a spine board, how do I keep them from aspirating blood or swallowing a bunch of blood that would cause nausea and vomiting? Have this magic device called a suction unit, and it has this magic hose that connects said suction unit to a tonsil tip suction, and I can keep all that suctioned out really good for my patient. If my patient has significant bleeding in the mouth, I am going to make sure they're strapped to that long spine board really well, and I'm going to prop that spine board up so that they are more on their side so that that blood pools more in the cheek, and I can keep it suctioned out easier rather than it building up in the posterior pharynx between times that I suction them, because I can't constantly suction them or I'm going to deprive them of oxygen, right? Okay. Appropriate monitoring devices. What the heck are we talking about here? They're just talking about using your SpO2 monitor and your pulse oximeter is also aka your SpO2 monitor. And then you could possibly have end-tidal CO2. You could have capnography available to monitor your patient. We'll roll about 5 more minutes and then we'll take a break. So we're getting a good baseline on everything from mental status all the way down to any swelling that we see, so that as we reassess, we can assess for any progression of that. Okay. Use direct pressure to control bleeding. You can use roller gauze and wrap that around the head. Do not apply excessive pressure with that roller gauze when you're wrapping a patient's head to control bleeding. If they have a skull fracture, let's say they have a comminuted skull fracture. They have it like a shattered skull, and there are little bone fragments there. If you put pressure, you could actually push those bone fragments down into the brain and cause trauma to the brain that's unnecessary, because you didn't need to apply that much pressure. So be careful with that. Err on the side of caution. Also, if you suspect there's cerebrospinal fluid running from the nose or the ears, then which would be indicative of a basilar skull fracture, you don't want to occlude the flow of that cerebrospinal fluid, or you're going to increase the intracranial pressure. We'll talk about that more in the next chapter. We can always use our chemical ice packs to try to keep some of this swelling down. That's good BLS. And someday when you guys are paramedics or physicians, I want to hear that you are using ice liberally to control swelling, because that is just good patient care. It decreases pain, it decreases swelling. applying ice to the neck could slow the swelling to the point that maybe it delays the need for an advanced airway for our patient. Probably not if you have that much neck trauma, but it's just good practice. Fractured teeth, dislodged teeth, avulsed teeth, all of those can cause massive bleeding, tongue lacerations. How do people get their tongues lacerated? Somehow, when they rear end that other car, they have their tongue between their teeth, and you have that impact, and let's say they're unrestrained and their head strikes the windshield and they have their tongue between their teeth. That can result in a major laceration. Those result in extensive bleeding. Those require lots of suctioning to keep the airway clear. Sometimes people are chewing and just bite the heck out of their tongue, and it bleeds and bleeds and bleeds. And sometimes they call 911 and we arrive to save the day. And sometimes all it takes is us to remind them to spit out into our little emesis bag, to spit frequently to keep the blood out of their mouths and keep from swallowing it. And sometimes it requires suctioning, but it's you will be called to far less serious events than someone who has a major tongue laceration from biting it. Doesn't sound what somebody calls an ambulance for, but if they will call to get a ride to get their prescription filled at the hospital, and some places you can't refuse service, so you have to give them a ride to get their prescriptions filled. They'll call for that. They'll call for a bleeding tongue after they bite it, and sometimes they bite it badly enough that they have to get a couple of sutures in their tongue. Teeth are sharp. Some people chew hard. They're in a hurry to eat that food. Got to hurry and get that burrito down so you can get another. Maybe they live in a boarding house. I don't know. Maybe they eat gruel, and they live in a setting like they had in oh man, what was the Charles Dickens book? If we're down to talking Charles Dickens, it's probably time to take a break. I also know a guy named Charles Dickens. I'm not quite old enough to have known Charles Dickens. Oliver is the musical that is based on the Dickens book, whatever. Anyway, when we get our sample history of these patients who have bleeding in their mouths and may have swallowed a lot of blood, when we're getting that sample history, ask them if they're having any nausea with that and have suction ready. We don't want them to aspirate if and when they vomit. Let's do one more slide and then we'll take a break. Okay, if some avulsed skin, you can have a skin avulsion that results in a flap of skin. You can have an avulsed skin where you have a big chunk of meat that is ripped out of your patient's head or face. And if time allows, you can take that chunk of meat that's been avulsed, that piece of tissue that's been avulsed, and take it with you, wrap it in a sterile dressing, put it in a plastic bag, keep it cool, but not directly on ice, and take it to the hospital with you. If you're treating life threats, you don't have time to be running around gathering up skin and managing it to transport it with your multi-systems trauma patient who's about to die. At the hospital, somebody, whether it's a surgeon, an ER doc, or down the road, maybe a plastic surgeon, will figure out what to do. But we don't have time in a life-threatening situation to be gathering up chunks of meat from our patient so that it might be placed back on our patient's face. more likely, it's rare that you're going to even find the piece of avulsed skin if it's been completely torn away. If it's still attached, and you have that flap, and they come in all sizes and shapes, everything you can imagine. Well, I don't know that I've seen one shaped like Texas, or more closely Pennsylvania maybe, but or Florida, even down there pointing down. But just irrigate, use sterile water, irrigate under that flap, and then gently pull the flap down and put a sterile dressing over it, dry sterile dressing, to hold it in place as best you can. Let's take a 5-minute break and come back and talk about eye injuries. Injuries of the eyes, back to things that make you go, ooh. That's once you lose the vision in an eye, at least up to this point, we don't have bionic eyes that I know of. So loss of vision in an eye usually means loss of vision for life. So these are very traumatic things for a patient. We can have an idea in our own minds as to whether our patient may have permanently lost vision in an eye because they have vitreous humor running down their cheek, but that assessment is done obviously by a physician at the hospital. It's not our job to make that determination. Tracking is what you call both eyes moving together in the same direction. When you have your patient follow your finger or your pen, when I was discussing the eye movement to the cardinal points of the compass, when you assess eyes, you can also do that with a finger, and you don't have to do all of the up and to the left, down to the right, all of that. You could just do, if you're just doing a rough pre-hospital, I just need to see if the eyes move, have them go left, right, up, down, and that could be enough. I sometimes hedge toward the side of overkill with some of this, but okay. Of course, you observe standard precautions. If it's wet and sticky and it ain't yours, protect yourself from it with the appropriate PPE. We don't want to do anything that aggravates any problems. So if our patient, if they've gotten, let's say they had a bunch of sawdust and wood chips were blown into their eyes somehow, and they may have little splinters on the posterior side of their eyelid. We don't want to do anything that has them move their eyes around all the time, because all we're doing is causing more and more corneal abrasions, little scratches of the cornea. So, and those are really painful, and it's cruel and unnecessary to do that. So and how do we get things out of the eyes? We irrigate with sterile saline solution. Bulb syringe, maybe. A lot of times I just took that, and you guys haven't been on the ambulance, so you don't have a clue what I'm talking about, but you have these 1-liter jugs of sterile normal saline, 0.9% sodium chloride solution in water, and a lot of times you can just, you unscrew the lid off of that and you irrigate from the medial side to the lateral side. So you're always irrigating away from the eye on the other side, because you don't want to wash something from one eye into the other and cause a 2-eyed problem when you only had a 1-eyed problem before. But you can just take that saline solution and use the bottle to irrigate with. A bulb syringe can work if maybe there's dirt in there and you need a little bit of force maybe to push that dirt to the side and and irrigate that out. You could do that. You can also rig up a nasal cannula so that there's a prong on each side of the bridge of the nose, and then you have to have IV tubing, and you have to have a bag of saline IV solution to connect that tubing to, and then you take the end of the administration set, which is what the IV tubing is, that the fluid runs through, and you cram the hub of that into the end of the nasal cannula that you would normally connect to your Christmas tree or connect to your regulator. Tape that together, and then you can continuously run saline solution into both eyes, and it's starting medially and irrigating laterally, and that can work pretty well. It depends on what I'm dealing with as to whether I would do that or just irrigate with the bulb syringe or with the bottle of saline solution itself. There's also something called a Morgan lens that can provide continuous irrigation. Looking at this, if you could picture a contact, like you put contacts in your eyes to see. If you can picture a contact that has something kind of like one of these prongs of this nasal cannula permanently affixed to it, and then that tubing goes up to a bag of normal saline IV solution, you start the fluid running with that, and it kind of builds a cushion of fluid on the surface of the eye, and then that provides constant irrigation around the eye. Those are not super expensive, but they're expensive enough that you're probably not going to find those on your ambulance. But that is what a Morgan lens is. If you see it, I used to have a picture of a Morgan lens in this slideshow, as well as a video of that being inserted and used, and I updated the slideshow and somehow took it out. So I apologize that you didn't get to see a Morgan lens. There's a picture in your book, I believe. If you've ever gotten some dirt or maybe a little bit of sawdust or something in your eye, and you still feel like it's in there after it's been irrigated out, after you've blinked and the tears have washed it away, that's one of the functions of tears, is to move dirt and things away from our eyes if it makes it past the lids and gets on the surface of the eye. You can get a small abrasion on the cornea or on the conjunctiva, and that abrasion makes it feel like that foreign body is still there when it's not there at all. Sometimes gentle irrigation helps wash things out of that are stuck to the cornea or out in the conjunctiva, and sometimes it doesn't help. Impaled objects, as you can imagine, very painful. The impaled object needs to be stabilized and bandaged in place. You cover the eye with a moist, sterile dressing, and then the old books used to show like a Dixie cup, if you know what that is, one of those little shot glass sized cups that people used to have in their bathrooms so they could, when they brush their teeth, they used a little cup to rinse with, and those were fantastic little things. All my friends' parents had little Dixie cup dispensers in the bathroom, and my mom taught me how to cup my hand and suck the water out of my hand, apparently because we couldn't afford Dixie cups. I don't know why we didn't have Dixie cups. Am I scarred for life? Apparently, so I'm still talking about. No, I don't care whether we had Dixie cups. You can take Surgi pads. You can take different bandaging materials you have on your ambulance, and you can stack those around an impaled object to stabilize that. And you can use this magic stuff that we have called 3-inch tape, and you can tear strips of that to tape it down to the face to stabilize that. And then we always cover both eyes with bulky dressings. Why? Because the eyes track together. Well, how is that important? Guy has impaled object in his eye, and you have it all. You think you have it pretty well stabilized, and you have everything packed around there. But every time you make a movement, every time you do something, your patient has a tendency to watch you with their other eye. And as they move their eye around, let's say it's impaled in their right eye, and you have that bulky dressing there, you have that stabilized in place, but every time you move, they move their left eye to try to watch you. The eyes track together, so they're moving that impaled object around all the time. Explain to them what you're doing and why, because they're going to fear that they've lost vision forever in one eye, and the last thing they want is to have the other one closed or at the other one bandaged so they can't see. So this involves really good explanation to your patient and tell them why I'm going to cover your other eye. It doesn't appear to be injured. I don't think there's anything wrong with it, but your eyes move together. And as I've already told you, you have something stuck in your other eye. So I'm going to bandage both eyes so you don't move your eyes around, and that can decrease the damage to your other eye. You didn't promise them that you were going to save the vision in their other eye. You made no promises other than you explain that you cover both eyes because they move together and you need to keep them from moving those around. Burns to the eye. You need to stop the burn to prevent further damage. How do you do that? Do you take a fire extinguisher and shoot it in their face and hope some gets in their eyes? Hopefully not. We're going to use that magic saline solution, or even if it's just regular old tap water. If that's all you had, it's going to be more irritating to the eye. Normal saline, 0.9% sodium chloride, that's the same salinity as blood and bodily fluids. So when we use normal saline solution, we're using the same salinity that the body's used to, so it's not going to cause the added irritation that tap water has, because the tap water is going to be hypotonic. It's going to have lower salinity than what normal saline has, and it's going to irritate the eye. But if that's all you have, that's what you use. But we need to get acids and alkali solutions, substances out of the eye, and we're going to do that with copious irrigation with water or saline. And I'll plant this seed in your heads now. I have paramedic students all the time, after they learn that there is a medication that we give. It's an electrolyte called sodium bicarbonate. If a patient has metabolic acidosis, we can give sodium bicarbonate to treat that acidosis. And sodium bicarbonate is like baking soda. It's like a baking soda solution. And so when you take Alka-Seltzer, that neutralizes stomach acid and makes your burning gut feel better when you have heartburn, right? So logically, you would think, oh, well, I could put some of that good old, and maybe you have a paramedic partner who wants to do this after you're out there on the street. Another reason I talk about this now, sometimes the thing that saves the patient from a bad paramedic's a good EMT who remembered something from a lecture. So Uh, you cannot, if a patient has acid burns in their eyes, you can't irrigate that away with sodium bicarbonate without causing further damage to the eye, because adding that sodium bicarbonate to that acid causes an exothermic reaction. It liberates heat as part of neutralizing that, and that heat is going to burn the eye. So, and the more acidic the substance is in the eye, the more acidic the chemical, the more heat that you will liberate by putting that bicarbonate in there. So don't let somebody do that, and you can tell them that the old fat bald guy said so, like they're going to care. But advocate for your patients. You don't try to embarrass the paramedic, but you could quietly ask the question, are you sure you want to do that? Because that's going to liberate heat, and that might damage the eye worse. And if they go ahead and do it, they're the paramedic, and they're the one who's going to have to answer for it. But they should listen to you. I mean, it just, if you're tactful. Ways to irrigate the eyes. We talked about the nasal cannula already. Here is, if you've worked in a chemistry lab, you've taken chemistry and been in a chemistry lab or in an industrial setting, you're familiar with that eye wash station. The old ones had like a cup that you pushed your orbit, the bony part, down on this cup thing, and that's what caused the water to come out, and you were leaning down and irrigated your eye anteriorly. This is that saline solution that I was talking about over here, the lower left picture, and that's, they're irrigating that eye. Don't see a bulb syringe. I suspect that they have that person leaning forward with a basin there, and probably using a bulb syringe, but I don't know. Chemical burns. We need to stop the burn. So you may have to force the eyelid open, like this bottom left picture here. Notice they have gloves on in 3 out of these 4 pictures. I'm going to flush from the inside corner to the outside corner, away from the other eye. If it's an alkali or a strong acid, we need continuous irrigation for 20 minutes. You're going to need extra hands, because you also still need to get vital signs and do all that cool stuff, right? After you complete the irrigation, let's say you have a really long transport time, or you're an EMT working at Boy Scout camp, and somebody gets something in their eye and you irrigate it for that 20 minutes, then you're going to put a clean, dry dressing to cover that eye and get them transported for treatment. Thermal burns in a fire. Most of the time, people will close their eyes in a fire and you won't have a thermal burn to the globe of the eye itself. In a flash situation, you have a flash fire, that may happen quickly enough that they don't have time to blink their eyes. I'm not an expert on flash fires, but with thermal burns and you have burn lids, that may be the extent of it. You may not be able to open that eye. You may be able to just put cool compresses over both eyes. So that's, you take a sterile dressing, put over both eyes, moisten it with sterile saline, keep pouring that saline on there to help cool that down. That may be the best thing you can do. Eye shields, you're probably not going to have those on your ambulance. Light burns, welding burns, UV light burns can be really painful. You can get a sunburn if you let's say, oh, what's a good scenario? They used to call it snow blindness. Somebody who's out on a when there's snow covering the ground, but it's sunny, and you have that snow reflect the light, not the snow reflecting. You have light reflecting up off that snow and into someone's eyes. Can get a significant burn to the eyes. It can even penetrate, light go through the pupil and have that long enough that could cause some internal damage. That's very, very unlikely, I would think. But what do you see? You see conjunctivitis. You have severe redness of the affected eye, and so a lot of times, if somebody, I've seen people who were welding for a long period of time, and maybe there was a crack in the lens of their welder's helmet, the face piece of the welder's helmet. I know you all know what I'm talking about. Waving my hands over my face doesn't help, but you have that flip up and down face shield, and it has a rectangular, usually shaped lens, and that lens is like sunglasses on steroids, and it filters out that bright light that's generated by that arc in that electrical arc in electrical arc welding. Looking at that bright light from that welding for even a few minutes can cause some significant burns to the conjunctiva. That's treated, as paramedics, we could put some tetracaine numbing eye drops in the patient's eyes till we can get them to the doctor, and usually I give them some oral pain medicine and tell them to cover their eyes with cool compresses. We're also going to do that, put cool compresses on their eyes. So if you have a patient who has, maybe they have burns to their eyes from welding, that's just the most common one I can think of, and put cool compresses on, and then you could call for an ALS unit to come give some pain medicine and maybe put some tetracaine eye drops in. If you don't have ALS available, it isn't a life threat. Even though they feel like they're going to die, you just put cool compresses over both eyes and transport them. Lacerations to the eye, if there's a laceration to the globe itself, don't apply any pressure to the eye. It may be that there's a laceration there, but that vitreous humor is hanging in there. It's staying inside the eye, and an ophthalmologist can put sutures in a laceration to the globe and keep that vitreous humor in there. It's freaky to see those little bitty sutures that they put in the globe in an eye, but they do it. My dad had some bad alkali burns to both eyes and he had safety glasses on with splash shields, but he was in a big building, and a front end loader ran over a 1 gallon container of this drain, like Drano, but it was industrial type Drano, and it sprayed that stuff out all over his face and head, but it went up under his safety glasses and into both eyes, and he developed glaucoma from it. He had a couple of corneal transplants, and his vision was very diminished. I always drove after Dad had those injuries. He had a lot of trouble with that the rest of his life. But he, after one of the corneal transplants, his eye started hurting real bad, and ophthalmologists met us at at his office on late on a Saturday afternoon, and actually I put numbing drops in my dad's eye, and as my dad sat there and talked to the doctor, I watched the doctor take like a probably like a 29 gauge needle on a syringe and insert that into my dad's eye through the sclera, through the white part of the eye, and to relieve pressure inside my dad's eye until the doctor could cut a little flap. I watched him do that too. He cut a little flap to help release that pressure from that traumatic glaucoma that my dad had developed. And Dad never felt a thing until the numbing drops wore off, and then he said it felt like there was something in his eye. Oh man, there was a needle. It went like it's like 14 inches long, and he stuck the whole thing in my dad's eye. As I told you, things in eyes make me go ooh, but I couldn't let my dad see that with his other eye because one eye wasn't seeing at the moment. Okay. Occasionally and a lot of times this happens with blunt force trauma that causes an orbit fracture. It can also cause eyeball to be displaced from the socket, so you have essentially an eyeball sitting out on somebody's cheek, it looks like, and the other one's still back in the socket. And this one is I've never seen this other than in pictures. Don't monkey with that eye. Don't do it. Don't try to put it back in place. Just put moist sterile dressings over both eyes. Keep your patient supine. Reassure them the best you can and transport for treatment. They can put that thing back in. Oh, that just, again, things that make me go, ooh, it's eyes. That anybody ever play racquetball without wearing your safety goggles? Don't ever do that again. That little racquetball fits almost perfectly in an adult orbit, and the pressure from that racquetball moving 120 miles an hour and striking in that unprotected 20% that we talked about earlier can actually rupture the globe of the eye, or it can cause retinal detachment. It can just annihilate an eyeball. Hyphema, blood in the anterior chamber. There's a picture in your book, and again, this I took it out of this dang slideshow for some reason, but it's blood that accumulates in the aqueous humor in the anterior chamber, so it's kind of like the iris is blooded out. You can't really see the iris, or it's discolored. That will resolve over time. It'll cause staining to the iris for a while. Just put ice on your patient's eye and cover both eyes and transport them to the hospital, keep them from moving their eyes. Retinal detachments, the guy I was talking about, or the guy, could be a lady. Guys are the ones who do these stupid things. Playing racquetball without goggles and get nailed in the eyeball with a racquetball. What I've seen with those is exactly what your book says. They may see floaters. If you've ever seen those yourself, it's just like just in your field of vision, there are little flecks of things floating, or it may be little light flashes, little specks in the field of vision with that eye. Those are indicative of a retinal detachment. As far as treatment for that, pre-hospitally, really what I've done is put sterile dressing on both eyes and then put and then irrigate it with saline so my patient feels like I'm doing something for them and get them to the hospital. Maybe that an ophthalmologist has to go in and do a laser surgery. That's what you call those things, lasers. Do a laser surgery to go in and repair that piece of retina. It may be that it can't be repaired. But again, wear your goggles if you play racquetball. There's 3 times. Maybe somebody out there needs to hear that, or I wouldn't feel compelled to repeat myself over and over, unless I'm vamping because I don't know what to say next. All right. Eye injuries, injuries that can appear to be eye injuries that could be indicative of a closed head injury. One pupil larger than the other. We've already talked about that. Eyes that don't track together. Disconjugate gaze is what that's called. Inability to follow your finger or your pen light to those cardinal compass points. Bleeding under the conjunctiva, protruding or bulging eyeball. If there's a possibility of a head injury, let's treat for a head injury, and we're going to have to move on through this chapter so you learn how. Okay, blast injuries can have foreign bodies within the globe. We've talked about how to manage those already. Follow your local protocol. Your local protocol should be to cover both eyes, right? Severe swelling, don't put a foot up there and grab with 2 hands and pry that eye open. Not that you could really do that, but you don't need to exert that kind of force. If there's severe swelling, get some ice on that and try to slow the swelling down, or may even help resolve a little of the swelling. But again, we treat life threats before we do that. So contact lenses, we're going to leave those suckers in place unless there's a chemical burn. Hard contacts are fairly easy to remove if you have the little suction cup that sticks to that hard contact and you can pull it out. Removing soft contacts from somebody else's eye may be really tough, but put a couple of drops of saline in the eye and try to pinch the lens between your thumb and index finger. So on the right would be the soft contact removal. On the left is the little suction cup. Epistaxis, nosebleed. Some are caused by digital trauma. How many knuckles can somebody get up their nose? Anterior nosebleeds, they usually originate from the nasal mucosa in the area of the nasal septum. It can look like a lot of blood, but really those bleed relatively slowly. Posterior nosebleed is much more severe, causes blood to drain down the back of the throat. So the injury is more back in the nasopharynx rather than anteriorly in the part of the nose that you see, what we generally refer to as the nose. Lots of nosebleeds from blunt force trauma. See, I had a buddy, every time he got in a fight, he got punched right in the left eye and his sclera would be all redded out for about 10 days. I just got punched in the nose and got a nosebleed. That messes with your vision for a minute, but really ticked me off to get hit in the nose. Blunt force trauma to the face. We need to treat our patient as if they have a spinal injury. We need to take spinal precautions, and we need to assess for signs and symptoms of a head injury. Okay. CSF, basilar skull fracture would be the cause of cerebrospinal fluid coming from the nose, ears, or even going down the back of your patient's throat. If you have a patient with head trauma and uh, ask them if they notice an unusual taste. And if they tell you they're tasting something really sweet, if you ask them if they taste something sweet, that's a leading question, and they might tell you yes, just because they don't know what else to say. But if you ask them if they're experiencing any unusual taste as you're going through your secondary survey, and they tell you that they have a really sweet taste in their mouth, that could be that they have a basilar skull fracture. The cerebrospinal fluid has a high glucose content, and that would be the reason for that sweet taste they have in their mouth. That would be rare. Usually if they have head trauma that's that significant, they can't communicate with you well enough to tell you what they taste. Always consider C-spine when you have this kind of trauma to your patient. We're going to talk more about this in the next chapter, so I'm going to bounce on through this pretty quick. A non-traumatic nosebleed. If we're not worried about C-spine, we can put our patient in a straight up sitting position on our cot, which we call what? A high Fowler's position. Place them in a high Fowler's position. You can have them lean their head forward, pinch their nostrils together, and have them spit out any blood that's going into their posterior pharynx, or we're not going to say posterior pharynx to our patients. Tell them if they feel blood running down the back of their throat, don't swallow it. Here's this emesis bag or emesis basin to spit it into. Injuries to the ear can affect hearing. They can affect balance. That should be an and/or, right? Can do both. We have external ear, which would be the pinna. We talked about that earlier. The middle ear and the inner ear. So the middle ear is here where the canal is, and then you reach the tympanic membrane. That divides the inner ear, where these bones that are involved in taking, so sound waves come in. Sound waves are channeled into the auditory through the auditory canal by the pinna. Sound waves move down to the tympanic membrane, and those sound waves create vibrations of the tympanic membrane, which vibrate these little bones called ossicles, and those vibrations are translated via the cochlea and the innervation by the vestibulocochlear nerve to the nerve impulses that go to our brains, which is where we interpret the sound we hear. So that is how that works. Ear avulsion, what is that? You get part of the pinna, the external portion of the ear, either amputated, which is what they're calling avulsed, or partially amputated. If it's partially amputated, put it approximately, irrigate it good, make sure there's no funcola, no dirt, gore, grime, grease down in between their head and that piece of the pinna that's peeled back. Irrigate that really well. Put that back in place the best you can and put a sterile dressing over it if it's still attached to the head. If it's not, take the avulsed piece of the ear, wrap it in sterile gauze. That's what you call that stuff, gauze. In sterile gauze, put that inside like a Ziploc baggie, a small plastic bag, and then put like a 4x4 on top of one of those chemical ice packs, and then put the ear that's inside the sterile dressing that's inside the plastic bag on top of that ice pack to keep that cool in the event that they might be able to reattach that. Tympanic membrane rupture, blast wave is a big way for that to happen. I've also seen it like sometimes in martial arts and in like in fighting class, One of the techniques they teach you is to like an escape technique to get away from somebody is to slam them over both ears with your hands cupped like that as hard as you can, and that pressure wave sometimes will cause them to release enough that you can get away, and that pressure change can rupture the tympanic membrane. Impaled object in the ear can rupture the tympanic membrane. It's very painful. Have difficulty hearing with a ruptured tympanic membrane. Also have ringing in that ear, or tinnitus is what you call ringing in the ear, and that can be disorienting. Another reason you slap somebody over the ears if they grab you, if that's what you can do. I would also recommend that going into EMS that you guys find a self-defense class and take it. Everything we do to protect ourselves is defensive, and you need to learn that. I'm not saying you're going to get grabbed. I'm not saying bad things are going to happen out there on the streets. I'm not saying that they won't either. It's best to be prepared, and that I'm not here to teach you that class. Let's see if we can see this. Maybe. So this would, uh-oh, I lost my slideshow. See if I can get it back. Oh yeah. All right, that's just a little diversion from all the dang death by PowerPoint. What happened there? Probably blunt force trauma to that ear caused some bleeding, and also some bleeding and other fluid to accumulate. What are they doing there? They're just doing a needle aspiration, taking a syringe and sucking that bloody fluid out of there. That'll decrease some pain. That's not in our scope of practice. You're not going to see, not even going to see paramedics running around doing that, but that popped up in my Facebook feed last night, and I thought it kind of fit to throw it in there somewhere. Okay. Kids poke things down in their ears. Adults do too. What do they tell you about cleaning your ears out with Q-tips or paper clips or any of that stuff? Don't do it. If you're not supposed to put anything smaller than your elbow in your ear. Why? Because you can't get your own elbow down in your canal and down there to cause trauma to your tympanic membrane. So that's why they tell you that. Okay. If there's clear fluid or kind of a yellowish tinged fluid coming from the ear, that may be indicative of a basilar skull fracture. We need to assess for that. Facial fractures, we talked about that. Unless it's your face, those aren't acute emergencies. Your face, your spouse's face, or your kid's face. They can cause serious bleeding. They can cause internal bleeding. Yeah, so you need to be ready with suction. Facial fractures, let's get those chemical ice packs on there to decrease that swelling. You're going to use that ice for at least the first 24 hours. These facial fractures heal fairly slowly, so they can be repaired within about 7 to 10 days. Usually maxillofacial surgeon, oral maxillofacial surgeon is the surgeon that goes in and repairs those. If your patient has loose dentures or a loose dental bridge, or they're chunks of teeth fragments or loose teeth, we're going to gather those up and get them out of our patient's airway. Transport them with the patient. Okay. Dental injuries, again, those can cause significant bleeding, so be ready with the suction. If you have a patient with a tooth that's been knocked out and you have the tooth, handle that tooth by the crown where the shiny part is. Don't touch the root. Gonna wash it off with sterile saline. You're not going to have cold milk on your ambulance, probably. You're not going to have tooth storage solution that costs too much. Contact medical control. They will advise you, more than likely, they're going to have you put that tooth in a container and pour sterile saline in there with it. And you got about 20 minutes to an hour for that thing to be reimplanted. At the paramedic level, we at least talk about field reimplantation of a tooth with the advice and consent or under orders of medical control. I was using some language from the Constitution there. Federal judges are appointed and confirmed with the advice and consent of the Senate. If you remember that, this isn't that class either. But I don't know why that popped in my stupid head. I'm getting punchy, I guess. Okay. But at the EMT level, go ahead and contact medical control. If you're holding a tooth by the crown, the shiny part, rather than the root, and you see exactly where it fits, then if you're going to have an extended transport time, contact medical control and ask them what they want you to do with that. They may tell you to attempt to reinsert that. And if you have an order from a physician, that's a basic skill. It's not an advanced skill. Impaled object in the cheek, don't remove it unless it is occluding the airway or interfering with your ability to do CPR. Control bleeding with direct pressure, stabilize the object in the cheek, suction, 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 and transport. Neck injuries, just depends on the level of the neck injury. As to the problem, blast injuries, you can see crushing injuries from the impact of flying objects. It could be back in the days before most people wore seat belts. It was really common to have someone with blunt force trauma to the neck from the steering wheel. And also, depending on what somebody uses to try to commit suicide by hanging, if they use a slip knot and that slides down, that can crush the trachea. Very rare. It's very rare that you'd have a hanging that's like the Old West execution type hanging that results in a fracture, subluxation of the C-spine and snaps the spinal cord in half. More likely, you're going to have an asphyxiation by hanging with calls you run, and occasionally those can result in a crushed trachea or a fractured trachea. You would know if you had a fractured trachea, and as you check the trachea to see if it's midline, you can feel crepitus, or you may just feel subcutaneous emphysema. Feel that Rice Krispies feeling as you palpate the neck. You may see lots of edema, ecchymosis, all that swelling in the neck. If somebody has an injury to their larynx, they may not be able to speak, or they may have a real raspy, hoarse sounding voice, difficulty swallowing, all those things. This can result, these injuries to the neck can result in complete airway obstruction, and this is internal damage that's causing progressive swelling. We can't treat that externally, so we need ALS to to insert an advanced airway, whether it's surgical or non-surgical, to manage that patient's airway. So call ALS early and often for that one. Penetrating injuries. We want to control the bleeding. We also want to get an occlusive dressing over that open neck wound. Err on the side of caution. If you have a patient with a neck wound, go ahead and put an occlusive dressing on that. It's not going to hurt a thing, and you may protect your patient from an air embolism, and we talked about those earlier. Laryngeal injuries, signs and symptoms. Respiratory distress, hoarseness, pain, difficulty swallowing, cyanosis, pale skin, oh man, sputum in the wound. That's spit coming out of the wrong places. Subcu emphysema, that's that air, that Rice Krispies feeling as you palpate the neck. Bruising to the neck, hematoma, that's like a goose egg on the forehead, except move it down to the neck. Bleeding, we're going to provide oxygen. We're going to ventilate our patient. Call ALS early if we need them. If there's any chance there's a progressive swelling and our patient needs an advanced airway, if there's a chance they're going to need an advanced airway, then let's get it now. It's rare that you're going to have that you would have anything other than a rigid collar, cervical collar on your ambulance. So how would you apply cervical immobilization to keep this patient with a laryngeal injury from moving their head around? You could take a couple of those big multi-trauma dressings, and you could kind of fold those up to make a soft collar to try to help remind the patient not to move their head. They may not move their head because it may hurt so bad when they move they're going to tell you their throat hurts really badly when they move their head, so they're not going to want to move their head. Or you could, if you have no other way to go, you could just put them, take a cervical immobilization device, put down on the cot with the blocks up against the head to keep them from moving their heads and not put a rigid collar on. And that's in that slideshow. Take 5, we'll cue the other one up, and that'll give us an hour and 15 minutes to do head and spinal trauma, which is just right. So I will cue that up and see you in 5 minutes.